Hi, everyone. Welcome to our diabetes wellness group for this month. I'm super excited to introduce Michael Blyumin. He is from San Diego. His background is he completed his PharmD at UCSF. And recently, in May 2022, he completed his pharmacy practice residency with an emphasis in ambulatory care with Stanford. His career interests include primary care, chronic disease management, with emphasis in diabetes care. I'm super excited to learn more from him about his presentation today on glucose monitoring and medication safety. So before we get started, if there's any questions that come up, please put them in the question and answer function in this webinar, and then I'll be asking the questions during or after the presentation. So without further ado, Michael, go ahead.
Thank you, Catherine. As Catherine mentioned, my name is Michael. I'm one of the ambulatory care clinical pharmacists here at Stanford, and today we're going to talk about glucose monitoring and a little bit about medication safety. So here are some of the objectives we're going to be going through today. So in terms of glucose monitoring, we'll be able to describe why glucose monitoring is important with diabetes, understand the timing of glucose monitoring and its effect on glucose targets, and understand different technologies used to measure blood glucose and how these technologies differ. In terms of medication safety, we'll be able to identify which medications have additional benefits in the setting of diabetes outside of just reducing A1C and blood glucose. Be able to understand how medications used in diabetes can affect body weight and how medications used in diabetes can increase the risk of hypoglycemia or low blood sugar. So let's get started with glucose monitoring. A little bit of background on glucose. So glucose is the main sugar found in the blood of the body, and the blood carries glucose to your body's cells, and your body's cells use that for energy. The main sources of glucose for our bodies is what we consume. Of course, any food or drink that has sugar in it will eventually get broken down into glucose, but also carbohydrates are one of the main sources. So carbohydrates are basically, you can think of them as complex sugars. Eventually your body breaks them down into the most functional unit, which is glucose. The other source of glucose for our body is the liver. So our liver stores a lot of glucose and then also releases or synthesizes the glucose when our body feels like it needs it. In terms of storage, glucose is mostly stored in our skeletal muscles, so our muscles like your arms, thighs, things like that, and then as well as the liver. Now, why should we measure blood sugar? So first, measuring blood sugar can help us make dietary choices. Of course, as we said, diet is one of the big components in terms of where we get our blood sugar from. So if we know what our blood sugar is and how certain foods affect our blood sugar, that will help inform our dietary choices and allow us to make dietary choices that are in line with keeping our diabetes in control. Also, by measuring our blood sugar, we can quickly know whether it's too high or too low, especially low blood sugar. It's something you really want to know immediately if that's something you're experiencing. It also ensures that our medication and doses are appropriate. As someone that helps patients choose regimens and adjust those regimens, it's really hard to make any informed decisions without data. And the real data that we need to look at is blood sugar data. And then monitoring blood sugar also, it helps us avoid complications of diabetes. So complications with our eyes, kidneys, heart, feet, nerves, etc. The only way we can really know that we've kept our diabetes in control is if we have some sort of steady blood sugar monitoring. Of course, we can also check the A1C, but that's really done only every 3 months. So to ensure, in between, and to ensure there's no highs or lows, we want to make sure we're monitoring our blood sugar. Along those lines, there's a lot of things that impact glucose. Here's a list of different things that can impact glucose. I think there's some, above like 20 items on here. But if we just look at, some of the things, of course, carbohydrates on the left, those will increase our blood sugar. Alcohol can increase or decrease the blood sugar, interestingly, depending on how it's consumed. Fats and proteins can affect how we absorb blood sugar. So we're familiar with foods. Medications, of course, can increase or decrease blood sugar, especially if we're using them for diabetes management. There are lots of other factors that may affect our blood sugar as well. For example, stress or poor sleep, exposure to sunburns, things like that, illnesses, acute illnesses, exercise, it can go up or down or stay the same. So, there's a lot of different things that can impact our glucose throughout the day. So it's important that we monitor our blood glucose. The other question comes up is, well, when do I monitor it? Yes, I know, it's important to monitor my blood sugar, but when should I do it? How often should I do it? In terms of frequency, it really depends on your individual case, depends on what medication you're taking, what kind of diabetes you have. Most of the time, at least, you're probably checking once a day. Some important times to consider is fasting levels, so checking blood sugar. This usually happens in the morning before food. Basically, a fasting level means that you haven't eaten or drinking anything for about 8 hours. This helps us understand the baseline blood sugar control. We know if the fasting level is increased, that at baseline, even without considering dietary, things in your diet, the blood sugar might be too high, or if it's too low, maybe the medication we're using to control the blood sugars is too strong. So that's why a fasting level is important. You can check before or after meals. This helps you understand how specific foods might be affecting your sugar levels. After meals, I think, is one of the most important times. If we check 1 to 2 hours after, we can see the effects of that meal. Did it spike our blood sugar? If you additionally check before, you can then see, I guess, where it's coming from, how big the rise is compared to, before and after. Also, before might be a good time to check if you're using something like insulin, where the meal might affect the dose of your medication. Before bedtime is another time. I know a lot of people like to check their blood sugar. It can be important if you're prone to overnight low blood sugar. So that might be another time to check. Really, anytime you feel any symptoms of low blood sugar, hypoglycemia, you should be checking your blood sugar to make sure that those symptoms are in fact related to your blood sugar, and then treat accordingly. And then if you have any illnesses going on, the stress of an acute illness on the body can increase your blood sugar. So it's important that we measure a little more frequently during those times, so we avoid complications of having persistent high blood sugar. So what are our targets? What numbers are we looking for? And we know when to measure, we know why it's important, but what do those numbers mean? So the blood sugar numbers really depend on your A1C goal. And people have different goals. Generally, it's between under 7 and under 8%, and that's an individual, decision that we make as providers as to what your appropriate goal is for you. And the reason the A1C, is related to our blood sugar goals is because those two numbers are inherently connected. So, achieving a A1C of under 7% means your blood sugar is roughly under 150 on average throughout the whole day. Now, of course, that changes depending on when we take it. So a fasting level with this kind of goal should be between about 80 to 130. So this is something like, as I said earlier, you wake up, you haven't had food or drink for about 8 hours. A postprandial or post-meal blood sugar, 1 to 2 hours after you eat, should be less than 180. So basically, if you look in between these two numbers, really, the before and after meals, it shouldn't rise more than 50 points. That would mean that your meal is in line with, something that's diabetes friendly, and also your medication is working appropriately. Now, if we look for a looser goal of under 8%, this can be commonly used if you're prone to low blood sugars. Then, of course, our targets can increase a little bit since the A1C goal is a little bit higher. So having a goal of less than 8%, that means on average throughout the day, your blood sugar is about, less than 180, hovering in the 180 area. So that means your fasting when you wake up is probably between 80 and 150. That's what we're aiming for. And then after your meal, 1 to 2 hours after you eat, we're aiming for it to be less than 200. And that should come out to a A1C of under 8%. Again, the rise you can see it hasn't changed. The rise is still, we don't really want it to go more than 50 points higher from whatever you ate. So how do we obtain our reading? Traditionally, we use glucometers. You see, we'll talk about two different devices. One is the glucometer, and the other one is the next device we'll talk about. Glucometers is something that everybody should have if they have a diagnosis of diabetes. It helps measure your blood sugar. It has several different components. So you can see here on the right, you have your meter, it tells you the reading. You have the test strip, which is inserted, which is where we drop a little bubble of blood on to get that reading. We have the lancet and the lancing device. So you can see here the lancet and the lancing device that's used to help obtain the finger stick for the blood drop. A sharps container is something you should have to dispose of the lancet and the test strip, since they're sharp and they have blood on them. And then a logbook or some way of recording your blood sugar. That's very important, especially when you meet with your provider, so that they have a good context for how your diabetes is doing. And it gives us a little more detail than an A1C would. And then, of course, with this kind of measuring, it requires a finger stick to get each reading. Something that may not be the most pleasant experience, but typically it shouldn't be too painful. And if it is, we're going to talk about another device where a finger stick is not needed regularly. So quick review on the steps of how to take blood sugar with a glucometer. You're going to make sure you wash your hands before you're going to engage in this process, since we are going to be pricking your finger, and we want to make sure it's clean. Before you start, insert the test strip into the meter. That way your meter is all set up and you don't have to fumble around with anything while you might have some blood on your finger. Next, we want to clean the fingertip you'll be using with some rubbing alcohol, let it dry. And then we're going to lance the side of the finger. The side of the fingertip, can get us a nice bubble of blood and should be kind of less painful than something like directly on top of the fingertip. Then you get that bubble that you see here in the picture, and you're just going to tap it to the edge of the test strip. You can see where exactly you want that. Really, you need a very minimal amount of blood typically. Then after that, the blood glucose appears. So you can see here it's 105. Hopefully she's fasting. That would be a great fasting reading. And then at that point, you just want to dispose of the test strip and the lancet you used to prick your finger in a sharps container. Now, some additional tips, that's like the basic, we went through the basic steps. Some additional tips, if needed, you can use an alternative site outside of the fingertip to measure your blood sugar. This is used if, it's really difficult to obtain any amount of blood with the fingertip. I've had a few patients where either the skin is hard or really just, it's unclear why, but the lancet device does not get a good bubble of blood. In this case, the exact alternative site really depends. It can be your palm or sides of the palm, forearm, but it's going to depend on the meter you're using to make sure that it's calibrated to those sites. Then we have the lancing device, which we can adjust. That's another tip that is not often mentioned. So the first thing I would do is, if you're not getting a good bubble or it's too painful, is making sure that you adjust the lancing device to a setting that's comfortable for you. So as you can see in this picture, it's pretty small, but there's a little mark here on the lancing device and some other marks over here. Basically, what that area of the lancing device allows for is for you to turn it to a deeper or more shallow setting. So for example, if you're in the default setting and then you're not getting enough blood, you can turn it to a deeper setting for a deeper poke, and maybe that will allow you to get enough blood to get a reading. Now, on the flip side, it might be too painful on the default setting and you're getting enough blood. So then you can turn it to a shallower setting to see if you can still get enough for a reading, but also you've decreased the amount of pain a finger stick will have. The other consideration is you can get a thinner lancet, if possible, a thinner needle to poke your finger and see if that helps with things like pain. Always want to ensure your test strips are not expired. An expired test strip, we can't really say that reading is accurate. And we don't often think about things like test strips expiring. So always check the expiration date on your bottle. And then the last thing is, if it's bothersome to always have to write down your blood sugar numbers, or you just don't have time, or you might forget, and then having to read off those numbers can take a long time for your doctor. In those cases, you can opt for a glucometer that connects to a mobile application on your phone. And some of those glucometers, at least the ones I've listed here, like One Touch VarioFlex or some of the AccuCheck products, that same mobile application on your phone can directly connect to our clinic so your doctor can see your blood sugar readings before we start the appointment. And that helps us kind of determine our plan just up front and gives us a lot of information. And you don't have to write them down because they're stored in this application. You don't have to send it to us because we can get them automatically. Something to consider.
Hey, Michael, we have one question about the
Sure.
test strips. Why would they expire?
So everything in the healthcare world expires. Anything from test strips to things that are even non-medicine, everything has an expiration date. So they're only calibrated for a certain amount of time, essentially. So the company can only guarantee that the reading the test strip is providing with the meter is only accurate if the test strips are within date. I mean, usually it's a pretty long time, like a year or so. You should run out really if you're testing regularly before the expiration date occurs. But if they're ever expired, I would head to the pharmacy, get a refill, or ask your provider to order a new prescription, because we just cannot guarantee the accuracy at that point because they're only tested to be accurate within the window that they're good for.
Thanks, Michael.
Sure. All right. So in terms of that record keeping, it's kind of where we left off of. I just wanted to provide an example for what a really good blood glucose log would look like if you're not using something that automatically is uploading your readings. So here you can see the date is on the left, so we know when these readings were. That's important because we need to correlate it with what medications you were taking at the time. Is this recent? Is this relevant? And then you have the times that you're taking the blood sugar. So for this particular person, they're checking it before breakfast, common fasting reading, and they're checking it post dinner. This might be their largest meal, so they really want to know how the diet is affecting their blood sugar. Then there's a little section for notes that we can write if there's anything interesting or maybe something that's affected our blood sugar that we want to relate to our provider. So on June 6th, this person had 127 before breakfast, 173 after dinner, and they wrote 2 hours after dinner here, so that's helpful. Great readings, and the notes were they had broccoli, baked chicken, a 4th cup of quinoa for dinner. So what on the surface sounds like a very healthy meal. They also mentioned they went for a 45-minute walk 1 hour after dinner. So also could have contributed to these better readings that we're seeing. Now the next day, we see a higher reading after dinner, and there's a note. It was a birthday dinner. There was pasta, there was bread, a little bit of tiramisu. So that you can see possibly why this blood sugar number is increased. And this kind of information is very valuable because without this information, it's hard to say if it's the medication that's not enough. We're not really sure why you're achieving such a high value. But with this information, we know, oh, it's most likely related to this dinner, which is not a usual dinner for this person, a carb-heavy dinner. The next day, it looks like the readings are again kind of back to where they were, and it's mentioned that the person did 30 minutes on the treadmill. They had a baked salmon for dinner. So it kind of explains back to what the regular routine is. Now the last reading here, you can see it's 65 and then 90. So very low readings, and they mention the time. And this is, again, very important to note because this sounds like this patient having low blood sugar. So then they even note, they woke up sweating, then they corrected the low blood sugar with 4 glucose tablets. After that, they had a whole wheat bread with peanut butter on it to keep their blood sugar steady. So all of these notes are very important because, for one, we want to make sure that we're correcting the low blood sugar, and 2, we can see that this actually happened, and we can kind of just start to figure out why this might have happened and how to avoid it in the future. So this would be a really good example of a good blood sugar log. So now we're going to give an opportunity for some knowledge checks, basically go over and reflect on what we had learned. True or false, if my A1C goal is less than 7%, then my fasting blood sugar yesterday of 158 was at goal. Is that true or is that false? So the answer to that would be false. Because if our A1C goal is under 7%, we're really trying to get to a fasting reading of 80 to 130. Now the next question says, I only want to check my blood sugar once per day, and I want to make sure my dinners are healthy. When would be the most helpful time for me to check my blood sugar? So it sounds like this person only wants to check once a day, but they're also very interested in particularly the dietary effects on blood sugar. So when is the best time for them to check their blood sugar? Is it fasting, immediately after dinner, 30 minutes after dinner, 2 hours after dinner, or before they go to bed, which is 4 hours after dinner? Here the answer would be 2 hours after dinner. Now that's the best time to check on, what our food has done to our blood sugar because we fully absorbed our meal at that point.
So Michael, for 2 hours after dinner, is this after the first bite or the last bite of food?
Yeah, so this would be after you basically start dinner. So if you started dinner at 7, first bite or so, you'd probably want to check between 8 and 9, probably closer to 9.
Perfect, thanks.
Yeah. All right, so that's our glucometer section. Continuing on with glucose monitoring, we're going to talk about the second device, which is a continuous glucose monitor, or a CGM. A lot of you might have seen these on commercials. They're making their rounds these days, and really these are really great devices. I think they're underutilized, and I often encourage my patients to see if they can get them because they provide a lot of helpful information. So, what are these CGMs, or continuous glucose monitors? These are glucose monitors that measure your sugar levels continuously throughout the day, as the name suggests. They use a sensor which detects interstitial fluid glucose, so a little bit different than blood glucose, and we'll go over what the few differences between those two numbers are. It uses a reader like a regular glucometer would, but you can also substitute the reader for just your regular smartphone, iPhone, or Android to scan the sensor and collect those readings. The sensors, depending on which one you get data from your reader every 5 to 15 minutes, and that data can be shared with your healthcare team, can be even shared with your family, friends, and as you can see, based on this setup, it's going to continuously catch those readings and continuously share those readings. It gets 24-hour sugar levels, and this allows us to see trends. It can also even alert you if you're having low or high blood sugar. So, often we hear patients have low blood sugar in the middle of the night, and they only really feel it when it's gotten so low that they're having symptoms that have woken them up. But before it even gets there, these types of systems can alert you. And then what's one of the most attractive features about these systems is that a finger stick is not required, and I put here in italics, most of the time. So to operate the system, you don't need a finger stick, but there are some times we might want to double check, and we're about to talk about that now. So blood glucose versus interstitial fluid glucose. So this is the difference between what a glucometer is checking versus what a CGM is checking. So a glucometer is checking blood glucose. We know that because we have to get a drop of blood to get a reading. But sensors, they check the interstitial fluid glucose. So when we eat something and we break it down, or the liver is releasing it, glucose gets into our bloodstream. At that point, it then diffuses from the bloodstream into the interstitial fluid, which is the fluid that bathes our tissues and cells. So if you look at this picture down here, you have a bloodstream, you have your sugar molecules, these orange molecules. And as this is, distributing throughout your body, and these sugar molecules are trying to make their way to the cells or in the tissue, it's going to leave the blood vessel and enter this fluid space, and eventually then into the cell. So blood sugar and interstitial fluid glucose are nearly identical when glucose levels are stable, which is why we can use these types of symptoms. Most of the time, they're equally accurate to a glucometer, but there are certain times where they are less accurate, and those times are when the rate of change of the blood glucose is more than kind of the stable time. So when you're having a time in your day that the blood sugar might be changing quickly, these CGMs are a little bit slower to respond to those changes, because as you can see, the blood sugar is always the blood sugar, but for your interstitial fluid sensor to sense it, it has to diffuse to that area. And so that takes some time. Sometimes the readings lag 10 to 15 minutes when the blood sugar is changing rapidly. Now, the question that then becomes, when are those cases when the blood sugar is changing rapidly? That really is immediately after meals, if you're exercising, if you're having low blood sugar and your body's trying to adjust that level, those are times where the blood sugar might be changing rapidly. So we often tell our patients, if they're using one of these systems and they happen to get a really low reading, or they get a low reading, it's great. The system is alerted to you to that. Let's double check it with a finger stick and then proceed from there to make sure we're treating it. And this is, as you can see, the device. It sits, the sensor, this is the sensor specifically. It has an adhesive layer that sticks on your skin, and then the small sensor that goes into the interstitial fluid. These sensors are not, depending on what system you get, sometimes they are like rigid, but on the more common systems, they're just kind of like this, almost like hairbrush type material. This might look painful in the way it's sitting, but I've put them on myself. It's very painless. You don't really feel it. So looking at the components of these systems, how do I use the system? What do I need? So the system consists of three main components. You have your sensor. As you can see, this person here is applying their sensor to their back of their arm. It's worn, the site is dependent on the system, so arm or abdomen. And the duration of time you can wear that sensor, again, is dependent on the system. So some systems are 10 days, some systems are 14 days. So you wear them consecutively those 14 days, you don't take them off, you can shower with them, you can do whatever you want with them. And then at 14 days, you pull it off like a bandage and put a new one on. To put the sensor on, the CGM comes with an applicator. So this is what this little device is. The sensor is not that big, it's like the size of a quarter. Or this is down here is another version of a sensor that are very small, but they come with an applicator that helps you attach it to wherever the site is. As we said, it measures your glucose every 5 to 15 minutes. Then there's a transmitter. So the transmitter helps transmit that information from the sensor to the reader. And this is done either through radio waves or Bluetooth, depending on if you're using a meter or your smartphone. Sometimes the sensor and the transmitter are combined into one device. So like the Freestyle Libre, it's all in one device. But the Dexcom, it has two devices, the sensor and then the transmitter. And then the reader, it's just as you're familiar with glucometer readers, but here the advantage is these devices have smartphone applications, so you can use your iPhone or Android to read it instead of the reader, since we're always really carrying our phones. And even you can use a smartwatch with some of the systems. So let's go over the most common systems. So the most common systems, especially in type 2 diabetes, type 1, there might be some other options available, is the Freestyle Libre 2 and the Dexcom G6. Now, the difference between choosing a reader will depend on some of the information we're about to talk about, but also a lot of it is dictated by insurance coverage and what's going to be more affordable. So here you see the picture of the Libre system, the reader or the smartphone application, and then the sensor and transmitter combination. It's about the size of a quarter, maybe less. And here we have the Dexcom. This is the applicator. This is the transmitter, and it's attached. It goes onto a sensor, which goes on your body, and then the reader if you're using a reader. The components, so here you have a sensor and a reader or a smartphone, and of course the applicator. Here the main difference is that you also have a transmitter. So the transmitter and the sensor are not combined. In terms of compatibility, they're both very similar. Before there was a little bit of difference, but now both of these systems can work with iPhone or Android. With most of the recent phones, it's compatible. With iPhone, it's really after iPhone 6S or 7 is compatible. With Android, there's a lot of different devices, so you always want to check. But with most new Android devices, they are compatible. Sensor timing, so the Libre, you wear it for 14 days and then you take it off and put a new one on. For the Dexcom, the sensor itself is only good for 10 days, but the transmitter is good for 90 days. So you take off the whole system and you leave the transmitter for 9 sensors, basically. The MARD, this is a score of how accurate the system is compared to a reference standard, which is a glucometer. And the 9.2% is in line with other glucometers. So this is, these are FDA approved, and they are on average shown to be equally reliable to other systems such as traditional glucometers. Now, some other things you might want to note: both of these systems offer alarms. Both of these systems offer alarms for low and high blood sugar. The site that you put it on is different. So we only use really mostly the FDA approved site. There are some off-label sites, but we try not to use them if we don't need to. So for the FDA approved site for the Libre, it's the back of the upper arm. So kind of where the tricep is, where we have a little bit of subcutaneous fat to attach it to. And then for the Dexcom, it's the abdomen. Something to note with these systems is there are certain medications that may interfere with how accurate the reading is. So with the Libre, the amount of vitamin C you should be taking in per day should really be less than 500 milligrams to ensure the accuracy of the reading. And high doses of aspirin can affect it. And then these are doses much higher than like what we typically would use. And then same with the Dexcom hydroxyurea, which is a very uncommon medication. And then acetaminophen or Tylenol at high doses can affect the reading. In terms of water resistance and depth, unless you're a deep sea diver, both of these are pretty much reliable for regular life activities. And then the sensor to reader distance is the same for both. This is basically the reading between how far, this is the distance between how far your reader can be from your sensor, basically from your body, to ensure you're still capturing all of that data. So here's an example of why we actually might want to use these systems and why they might be more helpful. So a traditional glucometer reading, you get a glucose reading for one point in time. So here we have the time, and here we have the glucose reading. So this person checked their glucose at 8 a.m. and it came out to be like, a little bit under 100, maybe let's say 95. This really only tells us that at this exact moment, my blood sugar is 95. It doesn't tell us what the blood sugar was at 6 a.m. It's not going to tell us the blood sugar is at 10 a.m. Now, this particular person checks their blood sugar 4 times a day. Not many people check their blood sugar that often. Not many people want to, poke their finger that often. So you can imagine with less checks, you have even less data. So this person checks their blood sugar 4 times a day. This red square is kind of telling us the target range between 80 to 100, 70 to 180. By the looks of it, they're always in target. So by the looks of the glucometer reading, they're always at goal. Now, if we use that same person uses a CGM, what we have is data points from 5 to 15 minutes of every hour. So here we see, yes, they were at goal here, here, and here, and here. But what we were missing is these undetected low blood sugar, since we didn't check our blood sugar at this time, and these undetected high blood sugar peaks. Because again, with a glucometer, you only know what the reading is at that specific moment. But with the CGM, it's checking your blood sugar continuously, or interstitial fluid glucose continuously. And so you can catch, these areas that we might not have seen before. Now, after you get a CGM, you get different types of reports from it. You get a lot of data from it. Now, typically as providers, we look at this type of report, which is called an ambulatory glucose profile report, or an AGP report. And let's talk about a little bit some of the numbers we see here, because this is a lot more information than you get from a glucometer. The top part will tell us some key metrics, things like time and target range, things like average glucose or glucose variability, and we're going to go into what those mean. It gives us an ambulatory glucose profile, which gives us a graph like we just saw, and allows us to see kind of on average where the blood sugar has been, what the trends are, where it goes low, where it goes high. Then it gives us a daily profile. So the ambulatory glucose profile on top, this is taking all of the daily readings and kind of averaging them and showing us an overlay. But the daily readings tell us, day to day, so on the 26th, on 27th, 28th, and it offers us a window into like what days were better, what days were worse, what might have been going on. So looking at that metrics, the top part, what are we looking for in terms of what those numbers mean? So the target, the number of days a CGM is worn. So for example, if you're wearing a Libre, the target would be you wore them all the time, so 14 days. Now, the percentage of time the CGM is active will tell us how, in those 14 days, how often was the CGM being, properly used and worn. So the target is we're at least being active with the CGM 70% of the 14 days that it's worn, or of the 10 days if you're using a Dexcom. Now, the mean glucose is, as it suggests, an average glucose reading. So that will tell you over the last 2 weeks or month, however you set your report to report out, whatever the time setting is, that was what the average glucose was for that time. So this can be really helpful to kind of give us an insight on what our A1C might be, since we know that an average blood sugar correlates with the A1C. The glucose management indicator, or a GMI, is kind of like their version of an A1C. It estimates what your A1C would be based on, the last 2 weeks or month or wherever the report is pulling the information from. And then there's this thing called a coefficient of variation, or CV. And this just tells us how variable the glucose has been. So how much variation there is throughout the day. Are you having a lot of highs and lows, or is it more steady and kind of smooth? So really for that number, we're looking at for it to be less than 36%, because above 36%, it would be considered unstable. Now, in terms of the actual numbers, what is considered time in target? As we said, it really depends on what time of day and how close to your meal that particular reading is. That will dictate, basically how high your blood sugar will be. So for the typical target range, this may vary depending on your goals, but the typical target range is 70 to 180. So we want the goal there of above 70% in target range. So your readings should be between 70 and 180, 70% of the time or higher. Now, there are some specific goals for, how often we want the blood sugar to be too high or too low. We really don't want it to be too low very often. Too high, you can see here, above 180, less than 25% of the time, above 250, less than 5% of the time. So this is how we can interpret your report, and you can interpret your report as well. You can get this yourself, these reports from the CGM. So now if we look at with that information at the ambulatory glucose profile here, we can see that on the top, it tells us the CGM was active 99.9% of the time. It was worn for 13 days. So this person is at goal for how active they're using it. Average glucose was 173. So depending on what their A1C goal is, it might be higher than you want, or maybe it's at goal. It's estimating, the GMI is estimating your A1C would be roughly 7.6% for the last 13 days. And the glucose variability was nearly 50%. So what this also tells us is that A1Cs are not very accurate. So, an A1C of 7.6%, which is what this report is suggesting, basically, that we would think that might be at goal or very close to goal. But the glucose variability is saying that, an A1C being an average, the actual numbers are really high and really low. They're very variable. So, this person might be experiencing low blood sugar, they might be experiencing very high blood sugar. On average, it is at goal, but really throughout the day, it's probably not at goal. So another reason why these CGMs are so valuable. Then on this side, we see the time and target range. The time and target range here is 47%. So lower than you would like. We want to see it above 70% depending on your goal. And so we can interpret kind of what's been going on throughout the day there. Next, we see the ambulatory glucose profile, and what do these numbers and colors mean. So in this green square is the target range, 70 to 180. The black line in the middle, that's the median number. So the numbers that are in the middle throughout that time of day. The numbers in the dark blue, those are the readings on 25 to 75% of the range. And then the numbers in the light blue are really, if you take all of the glucose numbers, 50 to 95% of those readings are within this range. So just by looking at this, we can see it's very variable. So the middle line is very far from the edges of these other lines. And the last thing we see here is with the daily log, some hyperglycemia or high blood sugar, and the hypoglycemia area is low blood sugar. So these red areas are where it's low, and these yellow areas are where it's gone high. And that can tell us kind of about what's been going on throughout each day. Let's do a knowledge check. So true or false, you never need to use a traditional glucometer and finger stick to check blood sugar if you use a CGM. Here the answer is false, because it's best practice to double check our low blood sugar readings from the CGM with the glucometer stick via finger stick. All right, let's move on to medication safety. Before we move on, do we want to answer any questions about that last section?
Yes, so we do have some questions. So one of the questions is, for A1C, someone's heard sometimes they're told goal is 7%, sometimes is 8%. What does this depend on?
Great question. So there's a fair amount of factors it might depend on. Most commonly, what we look at is a person's age. So that's kind of tied into the risk of low blood sugar. So as we try to get the A1C down, we're coming closer and closer to normalized sugar levels, but also since the medication is lowering the blood sugar, sometimes it can cause low blood sugar. And so if a patient experiences low blood sugar, they may, become dizzy, fatigued, confused even, and that can lead to things like falls. And falls can be very detrimental, especially as we get older. So age and risk of low blood sugar certainly dictates how strict we want to be on that 7% goal. Other things you might think about is, how realistic is it for a person to achieve less than 7% safely? What other conditions they may have, and also like lifestyle wise, what's going to be concordant with the patient's care goals of care.
Thank you. And last question for this section is, are the continuous glucose monitors and sensors okay for everyone to use? And then let's say someone was diagnosed with type 2 diabetes, do they need to start checking their blood sugar, just make diet changes, or both?
Yeah, good question. In terms of CGM, it's really, I think I can't really think of somebody it would not be appropriate for. I think if you're willing to use it, able to use the technology and able to get it covered or some way get it affordably, I would give it a try because, for all the reasons we had stated. For some people, they find the readings a little bit less accurate for whatever reason, or it might fall off. Usually there are ways to, fix these things and calibrate the machines, but those are the only times I've really seen patients kind of, this isn't for me. Type 2 diabetes, it's certainly helpful. Originally, they were designed for type 1 diabetes, especially to be used with insulin pumps, but we found it's very helpful for type 2 diabetes as well. So that's a CGM answer. And then in terms of if you're just diagnosed with diabetes, should you be checking your blood sugar, especially if you're only making dietary changes, you're not on medication? I think in those cases, it might be not as crucial to check your blood sugar, but it still might be good to check it every once in a while. I think if you're just making dietary changes, it'd still be wise to have a glucometer, especially if you're trying some more extreme diets or fasting, things that can lead to low blood sugar. But you still might want to check in regularly on what the blood sugar is to make sure it's under control. Because as we said, we only get A1C every so often. So if you want to know in between how well you're doing and keeping track of your diabetes control, the best way to do it would be check your blood sugar. This is a conversation you would have with your provider, though.
Thanks, Michael.
All right, let's move on to medication safety. This section is a lot more brief. So, we have a lot of different medications we use in diabetes. How do they work? Where do they work? So some medications work in the liver. This helps, lower the amount of glucose the liver is releasing. As we said, the liver stores and releases a lot of our body's sugar. Some medications improve the sensitivity of cells to insulin, since insulin resistance is the main issue with type 2 diabetes. And this helps insulin work better in muscles and fat. Some medications stimulate the pancreas to produce and release more insulin. Some medications slow down how fast your stomach is breaking food down. So, the absorption of sugar is a little bit more stable, less spiked. And some medication work in the kidneys and they help get rid of sugar through urination. Now, we talked about where these medications work. Well, what are the classes of medications? There are 8 common classes of medications. Metformin, technically the class is called biguanides, but really the only medication in this class is metformin. We have the sulfonylureas, which is things like glipizide. We have metiglanines, which is things basically only repaglinide and prandin these days, and very similar to sulfonylureas. We have dipeptidyl peptidase 4 inhibitors, or DPP4 inhibitors, which is things like Januvia. We have our glucagon-like protein 1 receptor agonist, so GLP-1 receptor agonist, commonly known as, and Ozempic, Trulicity, these are examples of this class. We have our sodium glucose cotransporter 2 inhibitors, or SGLT2 inhibitors. These are things like Jardiance. We have our really long name, thiazolidinedines, or TZDs. Most common medication in this, really the only medication used in this class is Actos or pioglitazone. And then of course we have our insulins. These are all medications that are available to us to use to help control specifically type 2 diabetes. And really, depending on, there's a lot of complex factors that go into why we choose certain medications for certain patients, but really you may see any of these throughout your course. Now, all of these diabetes medications we mentioned, they help lower blood sugar and A1C in combination with diet and exercise. Fundamentally, that is what we're doing, since having high blood sugar over a long period of time is what causes the complications of diabetes, increased risk of heart attacks or strokes or kidney injury, infection, neuropathy, retinopathy. All of these things we're trying to prevent by making sure the sugar is reduced to a normal level. So all of the medications approved for diabetes will be doing that in one way or another. Now, some medications have additional benefits outside of just glucose lowering. They may help with heart, prevent heart conditions, cardiovascular events, heart attacks and strokes. They may prevent kidney injury. They may help with fatty liver. Non-alcoholic fatty liver disease is very common with diabetes. And they may help, some medications may specifically help with weight loss, which also can be very helpful in diabetes. So what are the medications that may have these additional effects? So we have the sodium glucose cotransporter 2, SGLT2 inhibitors. They have 2 additional FDA-approved indications. So they help in reducing risk and/or hospitalizations related to cardiovascular events, so heart attacks, strokes, in patients with type 2 diabetes that have cardiovascular risk factors, things like, already they might have had a history of heart attack or stroke, or they have hypertension, or they have heart failure, other risk factors of the cardiovascular system. They also help prevent kidney injury and improve protein leakage from the kidneys, which is one of the first signs of kidney injury that is associated with or without diabetes. This class of medication, the SGLT2 inhibitors, is so good at preventing kidney injury that it's not only related to diabetes. It can just help it with, with patients that might have chronic kidney disease outside of diabetes. Now, outside of these FDA-approved indications, these medications are also beneficial with weight loss. They do show some weight loss profile, and that's related to how they work. Since these medications help us excrete more sugar through the urine, it kind of helps us lose some water weight, and we'll go into the mechanism of how the weight loss works as well. It also helps with blood pressure reduction. So here you see some examples. We have Jardiance, Farxiga, Invokana. These are all examples of SGLT2 inhibitors. Next, we have our glucagon-like peptide 1 receptor agonists, or GLP-1 receptor agonists. These have also 2 additional FDA-approved indications, specifically for this class of medication that's used in diabetes, so Ozempic, Trulicity, Victoza. It helps reduce risk related to major cardiovascular events, similar as we saw with SGLT2 inhibitors. Now, these same exact medications are used with a different brand name in chronic weight management. So things like Ozempic, they have a directly related medication, the same exact medication called Wegovy, which is only used and indicated in weight loss. And same with Victoza, which is liraglutide and used in diabetes. It has the same medication, liraglutide, branded under a different name, Saxenda, which is specifically indicated for weight loss. And then we have some additional benefits which are not FDA approved. They're like off-label benefits, but there have been studies that have shown that GLP-1 receptor agonists are very helpful in improving non-alcoholic fatty liver disease. That's likely related to the effects of weight loss and improvement in blood sugar control, given how a lot of the risk of non-alcoholic fatty liver disease is obesity and diabetes. So those are the additional benefits we see with some of the medication. Now, in terms of medication and weight, so different diabetes medications can affect your weight in different ways, and medications affect on weight are related to how these medications work in our bodies. So here we have two columns in this table. We have the weight loss or weight neutral column, so medications that cause weight loss or just don't really affect the weight one way or another. And things in this class include GLP-1 receptor agonists, things like Ozempic or Trulicity, SGLT2 inhibitors, things like Jardiance or Farxiga, DPP-4 inhibitors, things like Januvia or Tradjenta, and metformin. Now, on the other side, we have medications that might actually contribute to weight gain. Most commonly, these are medications like insulin, sulfonylureas or glipizide, glimepiride, metiglanide or repaglinide, and then thiazolidinedines or TZDs, things like Actos. They might contribute to weight gain. And the question is, why does this happen? Why are some weight loss? Why are some weight gain? So in terms of weight loss specifically, the GLP-1 receptor agonists, Ozempic, Trulicity, Victoza, these are examples of these medications. They slow gastric emptying, which basically means they slow how quickly your body is breaking down food in the stomach. And of course, that will make us feel full quicker, and it can decrease our appetite. And they also act on the area of the brain that regulates appetite and promotes what we call satiety, or it promotes feeling full. So, that combined with the slowed gastric emptying, that helps us basically decrease our appetite and with weight loss. Now, depending on the medication, the weight loss, which, when I say depending on medication, which GLP-1 RA you're using, Ozempic or Trulicity or Victoza, and depending on the time frame, it's been seen in trials, you can lose an average of 10 to 30 pounds, depending on the dose, on the, the length of time that's gone on, et cetera. The SGLT2 inhibitors, things like Jardiance, Farxiga, and Vocana, they also help with weight loss. This is likely a result to, glucose excretion. So we're excreting sugar through urine. That's how these medications work. And that basically allows us not to use that sugar. And of course, the more calories we ingest or use, specifically ingest and store, the higher the weight is. And also helps with diuresis or fluid loss, because we're flushing out all this sugar through our urine. We're losing some water weight as well. And depending on the medication, you can lose an average of 5 pounds. There's a lot of factors, but in the trials, the average loss was about 5 pounds. And this is more pronounced when you have higher blood sugar, because there's more blood sugar to excrete. If you're closer to goal, you might see less effect on weight loss. Lastly, we have metformin. Metformin is typically found to be weight neutral, maybe, no weight gain, but maybe a little weight loss. And really the mechanism is not super clear, but it might be, again, related to a decreased appetite as it's working on that area of the brain that regulates appetite. Now, lastly, weight gain. So we have medications and weight gain. So insulin, sulfonylureas, and metiglanide, these are things like any types of insulin, and then glipizide or Prandin or repaglinide. They have the same mechanism as to why they cause weight gain. So these medications, they're either giving insulin to your body exogenously, meaning like, outside of the body, we're adding insulin in, or they're increasing the amount of insulin we're making in our body. So, insulin promotes the storage of fat, protein, and glucose, and all of which can lead to weight gain over time. So fundamentally, based on the way it works, it can contribute to weight gain. Now, the TZDs, things like Actos, they work by binding a special receptor in fat tissue, muscles, and the liver to increase sensitivity to insulin and decrease glucose output from the liver. That's how it works. And it's not the same mechanism is responsible for increasing fluid retention and adding to subcutaneous fat. So some patients may see some swelling, that's the fluid retention. And some patients may see, a little bit of increase in subcutaneous fat. And what that means is, there's different layers of fat. Subcutaneous fat is located above the muscles right under the skin here. And then other things like visceral fat, that's inside of under the muscles inside the body cavity. But this really contributes to possibly a subcutaneous fat. Not to say this will happen, but it can happen. Now, the last section of medication safety we want to cover is the risk of hypoglycemia or low blood sugar. So medications that lower glucose in a what we call glucose-dependent manner do not cause a significant amount of low blood sugar. That's because they're basically working in concordance with your body to say, when the effects of this of this medication need to be more pronounced and less pronounced. So the glucose is lower, the medication isn't acting as actively. Now the glucose is higher, the medication is acting actively to bring it down. But it's not going to bring it down to a level that's going to cause low blood sugar. At least not, it's not been noted to really have that risk. Now things or medications in this class that are not really causing a lot of low blood sugar, things like metformin, your Ozempic, Trulicity, your Jardiance, Januvia, and Actos. On the flip side, there are medications that can have a more significant role in low blood sugar. So insulin and medication that increase insulin release, so things like glipizide, things like PharmD, they lower your glucose by increasing the concentration of insulin in your body. So this is not dependent on what the sugar is in your body. This is just, your body is releasing more insulin or getting more insulin, and that's going to lower the glucose. So this is not glucose dependent. And this includes all types of insulin, so that long-acting, short-acting, etc. So when is that risk of low blood sugar going to occur? That really depends on the type of agent you're taking. So here we have a graph of different insulin and when they work. So insulin, the different types is basically dependent on how quick they work. So we have a rapid acting insulin, it works about 3 to 5 hours after you take it. That is the period of time where you might see low blood sugar. You have your short acting, things like regular insulin, they work about 8 hours. So that is the period of time where it can be causing the low blood sugar, and so on and so forth. And intermediate acting, things like insulin and pH, those typically act about 12 hours long. Then you have your long acting, which lasts all day. So if you woke up with a fasting blood sugar that's low and you take long acting insulin or maybe even intermediate acting insulin, they might be responsible for that. Not necessarily, but they could be contributing. But if it's really occurring, 5 hours after you eat, 4 hours after you eat, or 4 hours after you take a medication, then it's really looking towards the short-acting insulins, that they might be the culprit. Now, PharmD has a half-life of about 1 hour. It's very short-acting, and because of that, the risk of low blood sugar is a little bit less. And so really, we're looking at the immediate time frame. If right after you took that medication, that's where the low blood sugar is occurring, then maybe PharmD's responsible. Glipizide has a half-life of about 2 to 5 hours, so that's kind of the time period where we might see something happening. And then glipizide XL, or the extended release, has a half-life of between 6 and 12 hours. So there, the low blood sugar effects can be pronounced, a little bit longer throughout the day, but also typically the release is a little bit more stable. So I think we see a little bit less low blood sugar with the extended release than we do with the immediate acting. Now let's do a quick knowledge check. Which of the following medications are considered either weight loss or weight neutral? So we have our GLP-1s, Ozempic, glipizide, Jardiance, metformin. So it's all of them but glipizide. Ozempic, Trulicity, they're weight loss or weight neutral. They're weight loss. SGLT2 inhibitors cause weight loss. Metformin is weight loss or weight neutral. Then we have which of the following medications have significant hypoglycemia risk? So we have metformin, GLP-1s, things like Ozempic, insulin, and sulfonylureas. And really, the GLP-1s and metformin don't have a significant hypoglycemia risk, but insulin and medications that release insulin in our body, sulfonylureas, they will cause low blood sugar. So now we've talked about all of the objectives we wanted to talk about. Does anybody have any final questions we can answer?
So we do have some questions in the chat. So the first one is regarding the medication, the SGLT2s.
Mm-hmm.
Would you anticipate more kidney problems because it increases urination?
Great question. So a lot of things go into that answer. So we don't anticipate more kidney issues, I guess, as a general statement. But they're only appropriate to use if you have a specific, amount of kidney function. If your kidney function is very low, we would not use this since, they're working in the kidneys. So they would require kidneys to be doing some filtration to actually exert their mechanism of action. In terms of kidney, damage, it's actually been shown to be protective, as we saw, against kidney injury. We would need to monitor your kidney levels after because it can affect the kidney levels, but not really usually in a detrimental way. It's just kind of might be slowing down how fast it's filtering. Your kidney is filtering what we call creatinine, which basically tells us, how well your kidneys are working. Usually this then stabilizes. So we don't really anticipate kidney issues. Sometimes I think there is a rare risk of kidney injury occurring. It is quite rare, because more often than not, we're using these to protect your kidneys because they improve kidney, like early signs of kidney injury. Before placing someone on this medication, we do look at their renal or kidney history, what their renal function is, to make sure it's appropriate. If it is appropriate, then we usually start it. Usually improves signs of kidney injury, but we do get labs done, 6 to 12 weeks after we start, to make sure things are stabilized, and it's not for some reason causing any acute kidney injury, which has been reported in the trials at a very low level, but for the most part, it's been shown to be beneficial.
Thank you. The next question is about side effects. So you did mention some, such as low blood sugars, weight gains. Are there any other common side effects for these medications? And in particular, someone is asking about dementia.
That is not what I would call a common side effect. It depends on what medication you're talking about. It's not really a side effect or a precaution that I'm familiar with any of these medications. Certainly not common. Something we consider a common side effect is something that occurs in 10% or more of the, been reported in the patients taking it. Yeah, off the top of my head, does not sound like something I'm aware of with any of these medications. But if you have a specific medication, definitely ask your provider to see if that's some sort of rare condition. But I would say no. It's also not understood why a lot of dementia is not fully understood as a disease state in the first place. So it'd really be hard to pinpoint how one medication would cause dementia, since we don't really know the true cause of dementia in the first place. It's still under research, and I'm not aware of that any of these medications have a higher correlation with dementia based on their studies.
Thank you. And one more question in the question and answer, and I apologize, I'm going to butcher the name of this medication, but this person asked, if you have side effects to Jardiance, can you still take
Farxiga.
Yes.
Yeah. So the medications they're the same class. So I guess it depends on what you mean by side effects. If one medication is, if Jardiance was not appropriate based on your kidney function, they have a very similar kidney function cutoff. So it depends, I guess, on the exact number, but typically, if you had like an allergic reaction, or you're just not tolerant, a lot of increased urination, that's like kind of a side effect based on how the medication works. You probably want to be cautious about using, Farxiga after, because it works the exact same way. So likely it'd be exerting very similar side effects, but I guess it really depends on what side effect it is that you're talking about.
Great, thank you. Looks like those are all the questions we have. Thank you so much, Michael, for your wonderful talk. I definitely learned a lot, and thank you everybody for attending this webinar. And once the recording is finished, it will be uploaded on the Health Library or our Stanford Healthcare YouTube channel.
Thank you everyone for participating.